Okay, I appreciate everybody coming. That's our 7-year-old ACL reconstruction. And at age 9, he blew out his other knee. So ACL doesn't discriminate in any age or gender. I want to thank John, Nick, and Jerry Palmieri, and I want to thank all of you for being here. And your interest in my presentation. I have no disclosures to report. And what I want to go over today is you're going to have an ACL athlete. They're going to be rehabbed. And I want to go over with you, in our experiences, the physical deficits that still remain that you're going to have to work on, even though they're done with their rehab, okay, as a strength and conditioning coach. So if you look at ACL reconstructive surgeries over 4 years, there was a total of 202 performed in the NFL. Half of them were done before the first game of the season. So you're not in a great situation with the CBA because you just don't have the time to train. And then if you think about that period of time versus the rest of the season, including to the Super Bowl, that's when the other half of the ACLs occurred over this 4-year period. Non-playoff teams spent a lot more money, had a lot more people out in regards to salaries than the playoff teams, right? Because since their athletes weren't injured, it helped them get to the playoffs. And overall, on average, is almost $9 million. We know that playing surfaces play a role, right? Artificial turf has a very strong grip. Its coefficient of friction grips the foot and doesn't release. And so in this study by Dr. Hirschman, who's one of the team physicians for the Jets, 67% incidence of ACL sprains, higher incidence in ankle sprains on field turf versus grass. So if you play on field turf, just another issue to deal with. College, I'm going over research first because this way you get a little bit of the science. We'll get into the art of it a little bit. These years, 318 ACL injuries, about 1.5 per 10,000 exposures. It means practice, games, etc. We know you're 10 times more likely to be injured at a game day, right? Nothing matches game day. You guys know that. Artificial turf is higher. In this study, contact was higher than non-contact. There's plenty of studies that show non-contact is higher than contact. But look at the positions most often injured. They're positions of velocity. And after their rehab, if you look at research, they say, okay, we go back. These deficits occur, and they're documented in the research, even though they're done with their rehab. In this study, this gentleman is done in Italy. They looked at soccer players over 5 years. And he looked at their physical qualities before they were injured, not comparing it to the other leg. And he found that at 6 months post-op, they're 97% what they were before the injury, but rate of force production, the ability to go 0 to 60 was only 63%. And it took a year to get to 90% or better. Again, we're talking about velocity. And thus, his statement was, should we really use strength as a criteria for return to play, or should we include velocity and rate of force production? Look at this study. All right, we know that strength factors, all right, and we'll talk about strength. Arden did a study, 48 studies, almost 6,000 participants, only 44% returned to competitive sports. Not a good record. Number one factor, why they didn't return to sports? Kinesiophobia. They're afraid to utilize and load the limb after ACL reconstruction. It's a big problem. You got to give them confidence. So when we talk about athletic performance, what I've been taught by my mentors is this. The fastest, most powerful athletes in the world, running, jumping, throwing, swinging, whatever, put the most force into the ground in the shortest period of time. And that's shown there by Weiland and by men with sprinters. And that's what we need to do. We need to get our people to put force back into the ground in the shortest period of time. And if you look at a sprint, essentially as ground contact time decreases, velocity increases. Force into the ground in the shortest period of time. And so what happens with our ACL reconstructed athletes? They can't handle the ground surface area. They can't propulse off the ground. They can't brake. They can't change direction. That's the problem. It takes time to get these qualities again. And so where we developed in our training, when it was in strength and conditioning, And in our rehab, we use Al Vermeil's hierarchy of athletic development. Al Vermeil's a good friend, and he's one of my mentors. And so what Al does is that he evaluates and tests his athletes just like we do in therapy, right? And then he develops a work capacity. What's work capacity? The ability to perform exercises time and time again without excessive fatigue. Not fatigue, but excessive fatigue. Because we know when you get overtired, bad things happen. Kinesthetic sense, force production's down, etc. There's a pitch count in baseball for a reason, right? And then you develop different physical qualities. Strength, explosive strength or power, elastic reactive strength, and then speed. And what's important to note is that each physical quality is dependent upon the development, the optimal development of its predecessor, with strength being the foundation. Your people have to be strong. So think of it this way. If strength is the ability to produce force, and you can't produce adequate levels of force, how are you going to produce force quickly? How are you going to be powerful? And such, how are you going to be elastic, etc. We adapted it in rehab that we need, after evaluating tests, we need mobility and movement, right? If people are in crutches, they got to be able to move. If they're not, if they can't assume the exercise position, mobility, how are they going to perform the exercise? And then sometimes you might have to have some muscle re-education. Was there a long tourniquet time? What was the anesthesia, et cetera? And once we have mobility, movement, and we know the muscles are firing, then we could develop a work capacity. We use Javoric complexes a lot. You can use whatever you want. And then we get into the physical qualities. So we have developed a return to play testing. And that's what I want to go over with you. Our results looking at 200 ACLs. And here's our return to play testing. First, we look at knee range of motion, passive and active, right? And then we do Vermeil's hierarchy. They get strength tests. If they fail the strength test, how would they possibly pass the power test? So we give them a strength program, or they stay with us, and then they come back. If they pass the strength program, then they do the power. If they fail the power, we give them a power program, and then they come back and retest there. And so on until they pass each category of exercise, and then either they return to play, practice, or training, depending on their time of year. So this is what we observe. In physical therapy, most people achieve passive range of motion, right? They sit long-seated, they get their heel to their butt, they put them on their stomach, they get their heel to their butt. And that's important because you need the soft tissue compliance, the flexibility, to assume the mobility of running or whatever else you're going to do. But they don't get it actively. So why do you need it actively? That's the position there. If you don't, we cue stepping over the knee. If you don't get it actively, you'll step below the knee, you'll scuff the ground, and you will slow yourself down. And as you know, since running is a cyclical event, if you have a bad swing phase, you have a bad stance phase. If you have a bad left leg, you have a bad right leg. So you need to achieve active range of motion, not just passive. And you'll find when you get your post-op ACL, post-rehab ACL, they will not achieve active range of motion. So here's a guy who's up in, Derek Hansen, who works. I was up in Vancouver. Here's a Canadian football player, 13 weeks post-op, left ACL reconstruction, right? You start running or so. Look at his heel height. Obviously, it's his left knee. You could see the sleeve. Non-op, post-op. Non-op, post-op. He doesn't have active range of motion. You need to work on that. Here he is from the rear. If I can get it. Look at that heel height. What do you think his swing phase is going to be? How's he going to run where he was before? But he's got it passively. Here's a young lady that came to us from a big D1 university, soccer player. 5 months post-op, came to us on Christmas break. Put her against the wall, have her do butt kicks. 5 months post-op, look at her heel height. It's her left knee. How do you think she's going to run? But she has it passively. So if you don't have active range of motion, game over. We don't even test you. And so how are you going to get it? You can do track and field drills, right? There's no reason why as soon as you start walking without crutches, you can't have them stand and start doing butt kicks. And if you think of the mock drills, we take the A series, start doing A walks if they're walking without crutches. Start doing A marches. Then progress into low A skips, high A skips, A running. And then you can take them out. And as they go through that sequence, you will achieve active range of motion. And if they do that in rehab, the time you get them, you won't have to worry about it. You could just start your running progressions. So this is something that could be done early in the rehab process. Typically, when you see a return to play, these are all valid and substantiated tests, right? They look at range of motion. Again, it's usually passive. They look at strength. They look at functional testing, whatever that is, hop testing, running, cutting, etc. Okay? And then they say, okay, you're cleared to train, you're cleared to practice, you're cleared to go to game day. So here's a study. And what do? We always compare it to the other leg, right? So let's talk about that for a second. Here's a study looking at the op leg as compared to the non-op leg, and generally as a standard, it's usually 90% or better. Some studies will say you could use 85%, but usually when you're 90% of the non-op leg, you're good to go, right? Okay. Control groups, not even athletes. The ACL reconstructed leg had extensor deficits of almost 25% and flexor deficits of 26%. The non-op leg couldn't match control groups. They had a knee extensor deficit, your quads, right? 21%, knee flexor deficit, 13.5%. The non-op leg isn't even as good as the control group, but we're using that as a standard. Look at this study. Some of the athletes, all right, they look at quadricep strength and hop test scores. And they have what's called EPIC. Just think of EPIC as the physical qualities before the injury, all right? And then they have limb symmetry, comparing it to the other leg. When you compare the op leg to the non-op leg, 40% of the athletes receive a 90%. 20 of the athletes, when compared to the physical qualities before they were injured, 20 athletes met 90%. 24 of the athletes who achieved 90% of comparing to the other leg didn't meet the standard of the physical qualities before they were injured. And so the conclusion in this study is when we compare it to the other leg, we may be overestimating knee function after ACL reconstruction and possibly increased risk of injury. And these findings raise a concern whether the variable of ACL return to sport criteria is stringent enough. Should we just use the other leg? So let me ask you this. Why don't we think about this? And these are the standards that we use. We're concerned with the opposite leg, but why aren't we concerned about the standards of the physical quality of sport of participation and of the position of participation? So here's a study from '91. Fry and Kramer, right? They looked at bench press, back squat, power clean. Division III, Division II, Division I athletes. And as you would figure, Division II athletes are stronger and more powerful than Division III. And Division I athletes are stronger and more powerful than Division II and III. All right? And the average squat was 192 kilos or 424 pounds. So when your ACL athlete is 90% or better, their non-op extremity, can they squat 424? Because that's the standard of the game for football in college, back in '91. What is it now? Well, if you want to get drafted, you better be able to squat 500 pounds. All right? Looking at almost 1,100 athletes, if you want to be in the 90th percentile, you better squat 500 pounds. That's the standard. It's not just the other leg. You better be strong. And you better be strong if you don't want to get injured. What are their sprint times? Because if you're running 5.0, you're not catching anybody and you're going to be caught. Can they run like they usually ran? Do they have active range of motion? Because if they don't have active range of motion, they could be strong, powerful, and elastic, but due to a biomechanical disadvantage, they're losing time. They got a poor running cycle. So look at this. Here's 3 guys that we work with. Male outside linebacker, male running back, male outside linebacker, 21, 20, 21 years old. 8 months post-op, 11 months post-op, 7 months post-op. And we're trying to figure what can we use that's a standard that's acceptable in research, because when you publish, you have to have valid standards. So we're going to look at vertical jump. It's a valid standard of athleticism. We use it in testing, right? And so when we look at single leg vertical jump, on their ACL side, there's a 15.5 inch, 13.5 inch, 10.5 inch. 98% the non-op extremity, right? They beat the 90% criteria. 90% of what the other extremity is, the non-op extremity. This 10.5 inch single leg vertical jump is 10% better than the non-operative extremity. So let's look at the standards of vertical jump for linebackers, running backs, and linebackers. If you want this guy at a 15.5 inch, when we look at their bilateral vertical jump, a 27.5 inch vertical jump for offensive linemen, it's the 40th percentile. A 30-inch vertical jump for a 20-year-old running back is in 10th percentile. And the last guy at an 18-inch vertical doesn't even register. They're all 90% or better the other leg, but they don't even register to the standards of a power test compared to their peers. And we're going to put them back on the field to play. So another test we use is a single leg depth jump. And we look at the time on the ground and their vertical height, right? Because we want to look at amortization and then how much force output. So if you look at them, again, here's the ground contact time on the op leg. Here's the ground contact time on the non-op leg. Here, red is, all right? The ground contact times are less compared to the non-op leg, but the height that they jump is also less. If you want to be a world-class sprinter, you better be 0.1 or better. If you want to be a pretty good athlete, you better be 0.2, 0.18 or better. Look at these numbers, 0.42, 0.53 on the non-op leg. They don't react to the ground well. So how do you train them? You got to apply unaccustomed stress. If they do a 2-pound straight leg raise right out of surgery, they've never done that before, that's an unaccustomed stress. And Selye, who's a Hungarian endocrinologist, came up with this thing called the gas principle. And so your body's in homeostasis, right? And you get a shock to the system. The first time you have to pull an all-nighter in college. The first time your significant other breaks up with you. The first time you have to lift a load, make a jump, or run a speed you've not done before. And so the body goes, whoa, it's an alarm phase. What was that? And then the body recovers. But the body recovers not only to homeostasis, but to supercompensation. Why? Because the next load you lift that you never tried before, the next time somebody breaks up with you, and the next time you got to pull an all-nighter, you're prepared. Your body's been through it. If you overtrain, if your volume is too high or your stimulus is not high enough, then you detrain and you break down. You need to apply unaccustomed stresses for them to adapt and improve. So you look at motor unit recruitment, right? We know motor unit stimulates a number of nerves, and we go through a size principle. And generally we go from slow twitch to fast twitch, and those are the ones we want to recruit to enhance the whole muscle belly to contribute to the activity. And so to get the type 2B and the type 2X, which essentially you need to apply intensity. You need load to get up here. Otherwise, you're just training this area. You're not getting the whole muscle belly. And a concept that's easy to understand, and Derek Hansen was someone who really drilled this into me. A concept that's easy to understand but hard to trust is 90% or 95% intensity. Whether it's load, velocity, jump height, it's still sub-maximal. It's still safe. Just don't do it too much. The volume will kill you. And so I always tell this story. I was good friends with strength coach Johnny Parker. And I used to spend the off seasons with him in New York during his time with the Giants. And then he went to New England. And there was a year they went to the Super Bowl and they lost to the Packers. The year they lost to the Packers. And going into that playoff series, the first playoff game, he had 35 guys hit PRs in one or more lift. So if you want to peak, when do you want to peak? You want to peak during the playoffs. And you can have people hit 95%, 90% of an exercise once or twice a month in season. Or else, why did you do all this work in the off season if you're not going to keep it in season? Just keep your volumes low. So strength, right? We apply force into the ground. It's important for proper posture. We'll get into that. You need muscle and joint stiffness. You're running, you're cutting, you don't want to collapse like a folding chair. Joint stability, but most importantly, it's the physical quality where all the qualities evolve. Change of direction, acceleration, deceleration, acceleration. We talk about tensile strength. It's the capacity of a structure. Now we're talking about muscle to withstand loading, right? Eccentrically, you're hitting the brakes. We know weaker athletes sustain more muscle mechanical damage than stronger athletes. We also know that weaker athletes put more demands on ligaments. Even if though they may be very elastic genetically, if they're not strong, they're going to beat up the ligaments and the anatomy of the joint structure. And there is research showing that change in direction performance is specifically correlated to relative strength values. If nothing else, get your post-ACL patients strong again. Because they can't be anything else unless they're strong. They can't go up the hierarchy. We're big on squatting. We know it decreases 10, 40-yard dash times, vertical squats. During my time working with Coach Parker, we didn't have a CBA. We used to lift 21 weeks, 12 weeks, week off, and 9 more weeks. And so we measured ACLs and PCLs with a knee ligament arthrometer, the integrity of the joint. We did 2,440 knee ligament tests. Only 8 came out abnormal. No structural change to normal ACLs and PCLs. We had 3 ACL reconstructions, one guy a year post-op, another guy 5 years, and one guy 10 years. It's too small a subject to publish it. So it's an observation. Point is you can squat, not worry about your ACL and your PCLs. All right? This is back in '94 we published that. And when you talk about squat exercise, you want to talk about effort and how deep should you go? Well, if you talk about muscle force, relative muscular effort, that's the muscle force required to perform a task, right? If I put a glass on a shelf, I need less muscle contribution than if I'm going to try to push press 225. It's just relative to the task at hand. So here's a study looking at quads, ankles, hips, the engine. What's more important, the depth or the load? Guess what? With squatting for the quads, depth was more important in regards to bringing out muscular effort, even though you need both. So in rehab, you can teach with body weight and light loads to get deep, unless there's a contraindication. We'll get into that. With the gastrocs, load was more important, but the engine, the hips, you need both. So a question is this, without a contraindication, why would you avoid the most beneficial position of an exercise? Because it's going to ruin the ACL. I just showed you a study from '94. It's not going to. But you do have to worry about joint and shear stresses, right? So a compressive force is you're pushing your hands together. A shear stress is you rub your hands back and forth. And shear stresses aren't good things. So if you have a meniscal repair, right? Especially if it's the posterior horn, you have a lateral edge, lateral third as the blood supply. They'll fix those, right? That's the red zone. When you squat deep, you get a rolling and a shear. So you don't want that because you'll ruin that repair. But you see that weight bearing from 0 to 90, you put a lot of pressure 4 times on the posterior meniscus position here. But meniscal movement is minimal, less than 60 degrees. So you can go to 60 when appropriate, speaking to the physician, and probably about 4 months or so, you can break parallel. I mean, you have to have the discussion with your physician and your trainers. But there's going to be a point in time you have to train. So for meniscal repairs, I've avoided for 4 months, but you could start limited range of motion stuff earlier. If you look at osteochondral lesions, right, little dings in the cartilage, right? Here's the front and back of patella, that's your femoral. Here's a cartilage defect in the back of the patella. They may do something like microfracture, not as much anymore. They may do something like Oates where they put plugs in. You have to allow that to heal, all right? So what are your concerns with the patellofemoral joint? Well, You should know this, and if you don't, look it up. There are different contact areas of the patella. So if you have a divot here that was filled in, then you better not go 45 degrees for a while. But if you're deep in here, or if you're out here, this is at 135 degrees of flexion. There's no reason why you can't go to 90 once healing has occurred. And here are the corresponding areas on the trochlea of the femur. And cartilage defects that happen, 72% of them happen either the patellofemoral compartment or on the femoral condyle. So that's where you're going to see this. ACL with its OCD, ACL with a meniscal repair. Doesn't mean you can't get there. You just need to know when you could get there. Here's a corresponding. Again, here are the positions on the femur. Here's the position on the patella in regards to range of motion. And what you have to be concerned about, here's the attachment of the quad and the tibial tubercle. As the quad comes over, the patella tendon, the quad comes over, you get great compressive forces. That's why you don't want to squat deep until healing has occurred, because you don't want to ruin those repairs, right? Because you can have great compression of the patella and the patellofemoral joint. One thing you're going to find too is that people aren't going to trust that leg, right? We talked about kinesiophobia. They're going to want to shift away from the surgical leg. So the way we correct it is we post the non-op leg. And by raising the non-op leg, it makes it more difficult for them to shift to that side. So you might use a 4-inch block. They just do body weight. You go to 3, then the 2, then the 1. Now they got good squatting pattern on level surface, and then you can load them. Your choice, bottom up, top down, squat, deadlift, whatever it may be. But get rid of that shift before you start loading them. So let's talk about power. Power is an acceleration, right? It's a rate of force development. Now we're strong enough, we need to go 0 to 60. So here's a guy, that's a 49-inch box. There's a guy we train. Okay? He's powerful. He's a minor league baseball player. Remember, difference between athleticism and skill. We do mid-thigh pulls with our ACL reconstruction. So depending on the athlete, the healing, etc., we do it anywhere from 6 to 8 weeks post-op, because we have to start the rate of force production early, so that when you get them, not only are they technically proficient in the lifts, but they can start to turn it on. So why this? Well, it's not technically difficult to perform a pull. She's only about a 30-degree knee angle, and she's got compression going through the joint to give her stability. If I can get this again. So bars at mid-thigh, upper third of the thigh. All right. Then when they're anywhere from 10 to 12 weeks post-op, we progress them to the left. Because they've got to be able to decelerate again. They've got to be able to deal with the ground surface area again. So they got to catch. And you may say, well, my big guys don't like the wrist or the hand. That's fine, then keep it light. It'll be easy for them. You're worried about velocity, not load at these early phases. So let's look at rate of force production. Oh, what did I just do? 125 milliseconds, right? 1/10 of a second on the ground. We're talking about 125 milliseconds. Remember the ground contacts before? 0.4, 0.5. Look at this. Control group. The ACL does better than the non-involved extremity for both extensors and flexors. So why do we keep just comparing it to the other leg? The other leg's not real good either. Why do we do mid-thigh pulls? Because mid-thigh pulls will produce peak power output better than a power clean, hang clean, etc. And it's not technically difficult. Mid-thigh pulls give you better rate of force production than the other lifts. I'm not saying you shouldn't do the other lifts. I'm just telling you why we do mid-thigh pulls. It's going to give you peak ground reaction forces. Force into the ground, shortest period of time. We use a vertical jump, right? Test the power. Takes you about 200 milliseconds. Mid-thigh pull only takes you 100 milliseconds. Boom. Why is that important? Because if you have an athletic task, whether to initiate or react, you only have about 200 milliseconds. That's why you need to turn it on. That's why you just can't be strong. You have to be strong and powerful or strong and elastic, for optimal performance. And if you want to look at strength athletes and you give them 500 milliseconds or more to produce force, yeah, they'll produce more force than a power athlete, but you don't have it. So you've got to be explosive, but you can't be explosive unless you're strong. So physical quality, elastic strength, right? When strength, when power, now we're going elastic. We've got to be able to rebound from the ground. So here's two guys. This is 5 3-foot hurdles, if I can get this. There we go. And I forget if it's a 4.5 or 5-foot box. These are baseball players. I obviously can't show you football players for a reason, but this guy is much bigger and much more athletic than the other guy. The guy in the blue is a shortstop, $100 million athlete. This guy's a minor league catcher. Don't confuse athleticism with skill. So depending on who you speak to Derek, you speak to Charlie, you speak to Al Vermeil, you probably become elastic at faster velocities, 6-7 meters a second. But here's a study back in '91 showing that you need to achieve speeds of 5 meters a second to become elastic. If your athlete can't run 5, 6, 7 meters a second, why are you doing plyos with them? You need to get them stronger and more powerful to reach the velocities so they can become elastic. Now, I'm not saying you don't train physical qualities, it's just where you're placing your emphasis. But unless they can reach the velocities where they're going to become elastic, don't worry about elastic abilities. Worry about the qualities that are going to get them there, then train elastic abilities. So, sprinters, 0.1, time to initiate, react, 0.2, ACL extremities, 0.42, non-involved extremities, 0.54, and a number of people, not all of them, they can't react to the ground surface. They're not strong enough, they're not powerful enough, they're not elastic enough. This is post-rehab. You're dying for them to get them back on the field. Look what's in front of you, not what you want it to be. So if you have a fully inflated basketball, so one of Derek's schematics, right, you can rebound from the ground. If you spend more time on the ground, like a partially deflated basketball, you're not going to go as far and as high. Same thing here. If you're not strong and maintain your posture, you're going to sink your hips. They sink their hips. I'm not talking about cutting, because that's an advantage on cutting. I'm talking about linear velocity. They drop their hips. So what happens? They step far out, and their leg, not only do they spend too much time on the ground, but instead of punching the ground, they start to paw the ground. So what happens? The hamstrings, instead of working like a hip extensor, work like a knee flexor. And over time, with volume and accumulative stress, you could pull a hamstring. So you want this vertical height so that you could reduce amortization, get a good stretch shortening, and produce force. You don't want to be out here. But they're out here because they're not strong enough. Speed. You got to develop the hierarchy, you got to be proficient in running mechanics, and you probably have to pick your parents well. Let's talk about ACL return. Let's talk about hamstring. So here's the hamstring muscle group, here's the semitendinosus. They use the semitendinosus and the gracilis, or just the semitendinosus, as a graft to replace the ACL. Has affected the hamstring. Here's the semimembranosus, and here's your biceps femoris. And your biceps femoris is where 83% of all running injuries occur. So now you got an intact muscle group where 83% of all running injuries occur, and you've used this other hamstring as your graft. Depends on the part of the country you're from. Kaiser in California, this is a study, but this is a statement by the American Orthopedic Society for Sports Medicine. For Kaiser Permanente in California, more hamstrings done than bone, tendon, bone, or allograft. In my part of the country, New York, we do more bone, tendon, bone. Why? Because the revision rates were higher with the hamstrings. And the doctors seem to feel it's a better graft. So you can use the central third patella tendon, or you can use your hamstrings, right? Here's your semitendinosus. So think about it. I'm taking out this piece of tendon, and then after I'm post-op, I'm not really active. What's happening to my hamstring muscle group? It's a problem. That's a picture of the graft. They go 4 strand, 6 strand, 8 strand, depending on the doc. That's where they harvest it. So it doesn't matter if you have a torn hamstring or you use the graft of a hamstring. And what happens? Healing occurs, doesn't matter. Unless you're an embryo, you scar. You have a heart attack, you scar in the heart. You cut your finger, you scar. You tear a muscle, you scar. And so you're going to have all this scarring here, and what happens? Things shorten. And so when you go to make ground contact through that swing phase, if you're shortened, you're predisposed to injury because you're almost overstriding. Even though the angle is appropriate, is the muscle because it's shortened. And so the fascicle, since they shorten, and there's 10 to 100 muscle fibers in a fascicle, they have to be re-lengthened so that you can assume a normal length of that hamstring. And that takes about 6 weeks. And you can use manual techniques. This is how we do it. You lay somebody on the ground, put a cuff weight around them. On the concentric phase, you help them. And then slowly, you extend the leg eccentrically. Because that's where they're going to get hurt, through the eccentric to concentric transition. But at least we're working some eccentric and getting a little bit of length. And over time, you will restore that fascicle length. This is a paper by a guy named Tim Tyler and his group. He's a physical therapist, a guy I know in New York. And I thought it was pretty clever. And he looked at 8 people he did this with in 2 years post-op with hamstring strains. They did not report re-injury. So here's the position you're going to be vulnerable. So think of this. The maximum length of your hamstring is noted at the late swing phase. And we know we have a shortened hamstring because of scarring. The biceps femoris, the muscle that's injured 83% of the time in all running injuries, has a peak musculotendinal length at the same time it has its peak EMG. That's good, right? Because I'm most susceptible, I want to be most active and strongest. But the semitendinosis, in a normal hamstring, the peak muscular length occurs significantly later than its maximum activation. But I've just used my semitendinosis as a graft. So what happened to that balance? We've got to reestablish that. We also know that at running speeds 85 to 95 max velocity in a normal hamstring, right? We have increased activation, but there's really no change in kinematics. But at 95% or full speed, which is what we want on the field of play, there's significantly different peak muscle activation times. And so if they become the same, we're in problems. If we're missing our semitendinosis, there could be problems. What's happening to our hamstrings? Are we setting ourselves up for injury? The other thing is the muscle, the hamstring, the biceps femoris, just like the biceps of your arm, has 2 heads, a short head and a long head. And guess what? Each head is innervated by a different nerve. So this whole thing is neuromuscular timing. I've lost my semitendinosis. I've got two heads in regards to different nerve innervation, right? Think about a pitcher. They have rotator cuff surgery or labral repair, right? We traditionally in a throwing program would look something like what? Short toss, long toss, pitching from flat ground, pitching off a mound. Because you want to maintain that scapular and the glenohumeral kinematics. But what happens in each phase? You increase velocity. You increase velocity to ensure that timing. Why is it different for a knee, a hip, or an ankle? So if you want to work with the hamstrings, you need to address Vermeil's hierarchy, but you need to sprint. You need to find the progression and then sprint. If you're not sprinting, how are you going to reestablish timing at maximum velocities? It doesn't just appear. So prepare them through the hierarchy, or however you do that. Then get them running. Make sure they have active range of motion. Make sure they have a good running gait. And go through a progression of speeds. But I will tell you, off-season as well as in-season, they need to sprint, or else why would this mechanism of timing remain? So Charlie Francis, again, speed is a result of the net forces acting on the ground. These athletes post-rehab cannot handle the ground surface area. They need to reestablish that for whatever reason. Lack of range of motion, lack of a physical quality, fear, all the above. And so here's Al Vermeil's hierarchy. You can't have top speed without being elastic. You can't be elastic without power, and you can't be power without being strong coming out of the blocks. That's the hierarchy. Here's another schematic from Derek Hansen. Here's 8 of his sprinters. They weigh anywhere from 165, 170 to 190 pounds. When something's presented in front of you, don't just look at a piece of paper. Look what's in front of you and think about it, okay? Here's a guy who's the 5th fastest, that let's say at 190 pounds, can squat 490. Does he need to be stronger to be faster? No, maybe he needs to be more elastic. Maybe he needs better running technique. He's certainly strong enough, right? Look at this guy. He can bench press more than he can squat. Are we to believe that the key to running velocity is the bench press? So maybe if he got stronger, he'd be a little faster. He may also need technique, etc. The bottom line is, please, just look at what's presented in front of you, because you're going to see a lot of things with these post-rehab ACLs that are still big deficits. So in summary, they're going to lack range of motion. Even if they get their strength back, when it comes to velocity type activities, they're going to lack it. They can't handle the ground surface area, all right? And they're going to be afraid, which is one reason why they lack this ground surface area. And don't just compare it to the other extremity. Look at the standards of your game, and do they meet 90% or better the standards of your game? Strength, power, deceleration abilities, velocity. All right? That's all I got for you. I really appreciate your time and your attention. If you have any questions, I'm happy to answer them if we have time for it. But thank you.